Okay, so we will start with today's session. Okay, let's start with today's session. So today is an introduction to the infection chapter. The infection chapter, people generally tend to struggle with the infection chapter. And the reason for that, I believe, is because there's this sort of multi-factored approach when it comes to the infection chapter. First of all, with anything that you're revising, you need to know the different medications within a particular chapter and the reasons why they are used. You've got this added complexity in the infection chapter with regards to understanding the microbiology. So it's this essentially this added complexity, and this added complexity with regards to the infection chapter determines your treatment options when it comes to what should you be treating a particular patient or a particular infection with. So just those multiple factors is what I feel like tends to scare trainee pharmacists quite a bit. Just to give you a background of my role within infection, currently I work within the interstitial lung disease department, but I worked as an antimicrobial pharmacist for 3 years prior to this role. And then following on from my antimicrobial pharmacist role, I worked within infectious diseases and HIV for about 6 to 7 months before I started this role. Currently, my teaching areas as a senior lecturer for undergraduate students is infection. So I still actively teach in infection. And I'm also a visiting lecturer and marker for the postgraduate antimicrobial resistance module. So anyone that's already a qualified pharmacist that's doing their diploma, their postgraduate diploma in clinical pharmacy, if they're picking the antimicrobial resistance module, I will generally either be marking those papers or moderating for that postgraduate diploma. So, has everyone taken a look at the MicroPharm Pro roadmap for this year? Yes, so the roadmap is essentially one thing that's extremely difficult is when you've got such a large library of information with your pro membership, you sometimes don't know where to start. So what I thought would be useful is to give you some guidance on where to start. And what I've done with this roadmap, this is the first time we've done a roadmap like this, is I've provided you with, I've broken it down into months. That's the first thing. And then I've also told you which webinars we are going to run in particular months. So, of course, it's August right now. So I'm doing the introduction to the GPhC exam webinar that was last week. And I'm going to upload that to your online platform this week. And also the introduction to the infection chapter webinar, which is today. But I've also got some recommendations of what modules I think would be useful for you to watch. And I've provided a monthly breakdown of what I think you should be watching in this particular month. And then also I give you information on so what I think you should be watching for this month and also the webinars that we're going to run over this month. So what's the aim of today's session? So the aim is to provide you an introduction to the infection chapter in accordance with the BNF. I'm also going to talk about considerations when it comes to prescribing antibiotics. And today we're going to go through high-risk antibiotics. So, like I said to you, the infection chapter is extremely difficult when it comes to looking at just the different complexities of microbiology, and also which antibiotics are appropriate for treating a particular infection. And what can tend to happen is the guidelines will change in accordance with resistance patterns. So we're used to see, let's say 5 to 10 years ago, the first line treatment would always be trimethoprim for a lower urinary tract infection. Now we hold back a bit on the use of trimethoprim, particularly because of resistance. And in many hospital trusts, nitrofurantoin is used more often because of resistance patterns. So I'm going to ask you quite a few questions today. We're going to make it as interactive as possible. And by doing it in this story format, hopefully you can absorb the information more easily. So you've got Ben, who's tested positive for COVID. Should Ben receive antibiotics? What do we think? Yep, so a relatively easy question to get started with. But a very good point in the comment section is the fact that there is a circumstance where Ben could or may need antibiotics, and that's if there's evidence of a secondary bacterial infection. What does it mean for it? What is a secondary bacterial infection? So it absolutely. So it starts as a viral infection, and then due to the fact that the patient has that initial viral infection, puts them at risk of a bacterial infection. So Ben, for example, could develop a bacterial infection on top of that initial viral infection, and that's where it may be appropriate for him to receive antibiotics. Does anyone know the rough percentage of secondary bacterial infections with COVID? Roughly about 8%. So very low in terms of, and this is for those that are tested. So bearing in mind, a lot of people are not tested at all. So yes, a very low percentage. Not all patients need antibiotics, as you probably know from all your experience of working through COVID. Terry has been admitted to the emergency department with sepsis of unknown origin. What should the medical team do before giving antibiotics? There's a lot of different considerations here. Take a culture for culture and sensitivity testing? Absolutely. When is it important to take the culture? So when they come through the door, what's the absolute first thing? So are we saying cultures and sensitivities before antibiotics? Why is it very important to take those cultures before antibiotics? What sort of antibiotics do you think we're going to give to Kerry? Yes, so the likelihood is we're going to give a broad spectrum antibiotic. What does broad spectrum mean? It means it covers a lot of different organisms, most gram-positive and gram-negative organisms, particularly with when we give the broader spectrum antibiotics to patients with sepsis of unknown origin. What that means is if you're covering a lot of those organisms and then you take a culture, your likelihood of identifying that organism that's causing the infection is reduced because of the fact that you may be treating that organism and therefore it doesn't grow when you take culture and sensitivity testing. So very important to take that into consideration. Does everyone understand that point before I move on? Yes, okay. So absolutely. So you take samples for microbiology, culture, and sensitivity testing. Raheem is a pharmacy student on his placement. He wants to learn more about spectrum activity. Why do we prefer narrow spectrum antibiotics over broad spectrum antibiotics? Yeah, so there's a lot of people are referring to resistance. So what do we mean by issues of resistance? Why is there a reduced likelihood? Absolutely. As someone mentioned, it doesn't kill the healthy bacteria, and therefore there's a reduced likelihood of you developing resistance. You're more likely to direct your activity to the organisms that are causing the problem, that are likely causing the infection. You're less, there's a few different factors. You're less likely to disturb your normal flora, so your normal organisms that normally reside within your gut, for example. If you're less likely to disturb those organisms, what do you think you're reducing the likelihood of as well? Yeah, you're reducing the likelihood of C. difficile as well. So you're reducing the likelihood of side effects, and you're also reducing the likelihood of resistance. If you're having an impact on other organisms, you are inherently increasing the risk of you identifying resistant organisms. Does everyone understand how broad spectrum antibiotics can increase the risk of C. diff? Does anyone not understand? And do they want me to explain? Yeah, okay, let's explain. So when you've got your gut, you've got millions of different organisms within your gut. I'm going to really simplify this. So if you have broad spectrum antibiotics, let's say they kill 95% of the bacteria within your gut. Many of the antibiotics that we currently use on the market don't have activity against C. difficile. If you're killing 95% of the organisms and C. difficile remains, why is that a problem? Absolutely. So someone's put in the chat, less competition. So there's less competition for nutrients. The organisms that you have, which is called your gut microflora, there's this harmony and balance with regards to resources and nutrients within the gut. And this means that there's due to this perfect balance, you're less likely to have side effects associated to the overgrowth of one particular organism. When there's way less competition, C. difficile can overgrow, can thrive, has less competition in nutrients. And what C. diff can do when there's overgrowth, it can start to attack that gut lining. And by doing so, it can cause a C. difficile infection. Patients can experience several watery bouts of diarrhea, and C. difficile can become life-threatening if it's untreated. So when you're going to start treating a patient with an antibacterial, so an antibiotic, what patient factors do you need to take into consideration? Let's consider the patient's allergy status, because of course that will determine which antibiotics they will receive. What about their kidney function, their liver function? In some cases can impact what you're going to use, their age, their weight, the severity of the infection. There are so many different factors to consider. So like I said to you, you've got different points. The renal function, where do you think, when do you think the renal function matters? So drugs that are renally cleared, absolutely. If you've got poor renal function, that inability to remove, if medications are removed from your body via the kidneys and you've got poor renal function, that means more of that medication can accumulate. More of the medication, increased risk of side effects. Liver function, if the liver function is impaired, sometimes medications are metabolized by the liver. That liver impairment can cause problems with regards to metabolizing those medications. Again, increased risk of accumulation. Age can sometimes be a factor when it comes to providing antibiotics. Weight can sometimes be a factor. Allergy status, of course, if a patient's allergic to a medication, you will have to give on an alternative. What factors would determine the route of administration? Okay, so someone's right on the ball. Severity, absolutely, Sally. Severity of the infection is extremely important. Let's talk about flucloxacillin, for example. How do we alter essentially the route of administration in accordance with severity here? Which infection do you think I'm referring to? No, so the particular type of infection rather than the bacteria. No, what do we normally use flucloxacillin for? Absolutely. Someone's put in a direct message, cellulitis. Absolutely. We use flucloxacillin for cellulitis. It has relatively narrow spectrum of activity. It has great activity against Staphylococcus aureus, which generally causes cellulitis. In terms of its route of administration, if you've got a severe case of cellulitis, you can use flucloxacillin intravenously. Why is it beneficial to use an antibiotic intravenously? You have absolute bioavailability, 100% bioavailability. If you're giving it orally, your bioavailability is greatly reduced. You have a faster onset of action and increased bioavailability. These are crucial when it comes to giving an antibiotic rapidly for a severe infection. But now let's go through high-risk antibiotics. So aminoglycosides, can you name examples of aminoglycosides? Amikacin, gentamicin, absolutely. Amikacin, gentamicin, neomycin, streptomycin, and tobramycin are the 5 examples that you need to remember. Gentamicin is the most commonly prescribed aminoglycoside in the UK, which there are similarities with other types of antibiotics. And the mycin at the end doesn't necessarily always mean it's an aminoglycoside. Azithromycin, clarithromycin, erythromycin all belong to another class of antibiotics. Which class is that? Macrolides. So it's important not to confuse macrolides with aminoglycosides. So that rule of the mycin at the end isn't the case with only aminoglycosides. You also have an example of vancomycin. Which antibiotic class does vancomycin belong to? Anyone? Vancomycin. We'll go through it later. So how do aminoglycosides work and which bacteria do they work against? Mostly gram-negative. So its activity is mostly against gram-negative. Does anyone know how they work? Yep, they inhibit they inhibit protein synthesis. So they bind irreversibly to the bacterial ribosome. And by doing so, they inhibit the production of protein. They lead to the production of abnormal or non-functional proteins. The majority of their activity is against gram-negative organisms. The only gram-positive organism that it's effective against is Staphylococcus aureus and in turn MRSA as well. So methicillin-resistant Staphylococcus aureus, which is also Staphylococcus aureus. It's just more resistant. The reason why it's active against Staphylococcus aureus only from the gram-positive organisms is it needs to use an oxygen-dependent transport system to make its way into the organism. Why does it need to make its way into the organism? Because it then needs to make its way to the bacterial ribosome and to prevent and inhibit protein synthesis. Now, it needs this oxygen-dependent transport system on the wall of bacteria to make its way in. That oxygen-dependent transport system from all gram-positive organisms is only found on Staphylococcus aureus. And then the rest of its activity is against many gram-negative organisms. It namely has good activity against Pseudomonas as well, which provides it great, which is one of the main reasons why it can be used in terms of its spectrum of activity. But like I said to you, active against some gram-positive bacteria and most gram-negative bacteria. Can you name some indications, some reasons for when it would be used? What types of infections am I referring to? So let's talk about the particular types of infection before we talk about the organism. And then I will start to talk about the organisms. So may be used for sepsis, particularly if you need coverage against either MRSA or Pseudomonas. It could be used for sepsis of the urinary tract. It can be used for diabetic foot infections, particularly this is because of its Pseudomonas activity. So can be some of the most common are infective endocarditis, meningitis, and hospital-acquired pneumonia. In infective endocarditis, one of the useful things is the fact that it has great activity against Staphylococcus aureus, which is that gram-positive bacteria, the only gram-positive bacteria it has activity against, because Staphylococcus aureus tends to cause infective endocarditis. It's one of the most common organisms of causing infective endocarditis. It's active against meningitis. It's used for meningitis. It's also used for hospital-acquired pneumonia. The reason why it's used more so for hospital-acquired pneumonia rather than community-acquired pneumonia is because hospital-acquired pneumonia, Pseudomonas can cause hospital-acquired pneumonia. The reason why Pseudomonas tends to cause more of a problem here rather than community-acquired is because Pseudomonas can generally be found in a hospital setting, so it increases the patient's risk of them having a pneumonia caused by Pseudomonas. So generally, you won't see aminoglycosides used very much for community-acquired pneumonia unless there's evidence of Pseudomonas. So JOYCE has been prescribed gentamicin for the treatment of infective endocarditis. Abdul, the junior doctor, wants to know the possible side effects of gentamicin. What are you going to tell Abdul? Ototoxicity. So there's a risk of hearing loss. It can cause irreversible ototoxicity. Any damage that occurs to the patient's hearing is irreversible. It can either demonstrate in two ways. There could be hearing loss, or there could be ringing in the ears, which is tinnitus. What else in terms of side effects? nephrotoxicity as well. So possibility of diarrhea, gastrointestinal issues, nephrotoxicity. The nephrotoxicity associated with gentamicin is reversible. So important to know that. The nephrotoxicity, ototoxicity, it can cause peripheral neuropathy, and it can also cause electrolyte disturbances. Glycopeptides. Can anyone give me examples of glycopeptides? Yeah, so we've got vancomycin, ticaplanin, telavancin, and dalbavancin are 4 examples. The most commonly used are vancomycin and ticaplanin. Dalbavancin is a relatively new antibiotic. It's starting to be used more often, and it's starting to be used more often. The usefulness of dalbavancin, it has this really long half-life of approximately 7 days. Another relatively new glycopeptide on the market is oritavancin as well, which also has a very long half-life, like dalbavancin. The most commonly prescribed in the UK is, of course, vancomycin. So how do they work, and which bacteria do they work against? So all of the activity is against gram-positive bacteria only. So there's no activity against gram-negative bacteria at all, and they inhibit cell wall synthesis. They do this in a different way to penicillins, but also penicillins also inhibit cell wall synthesis as well. So sometimes one of the considerations when you're giving an antibiotic is you don't want to give it alongside another medication, a high-risk antibiotic, for example, like a glycopeptide and aminoglycoside. You don't want to give it alongside another antibiotic or another medication that can cause that can also cause that severe reaction. So, for example, if you've got an ototoxic drug like vancomycin, you don't want to give it alongside another ototoxic drug. There are some circumstances where you'd give vancomycin and gentamicin together. Which circumstance do you think? Which infection do you think you could use both of them together? And has anyone seen this happen in practice? This this knowledge is possibly beyond the assessment, so I'll just go through it with you, just to give you some background understanding. Sometimes you may see, if you work in a hospital setting, you may see gentamicin and vancomycin used for infective endocarditis. And this is because they have a synergistic effect. So the vancomycin inhibits cell wall synthesis, so it inhibits formation of the cell wall, and it can make it easier for other antibiotics to enter via the cell wall. So therefore, this can make it easier for the gentamicin to get in to the bacteria, and then it makes it easier for that gentamicin to inhibit the production of proteins by making its way to the ribosomes. So that's why it has a synergistic effect. They both can work very well together. So they inhibit bacterial cell wall synthesis. They target the peptidoglycan layer of the cell wall, and this, of course, provides structural support and protection for the bacteria. It's gram-positive only. So can you name reasons, some indications for glycopeptide usage? They can be used for C. difficile infections. Which route of administration would it be if you're using a glycopeptide for C. difficile infection? Oral only. Why can you not give it IV? It acts locally within the gut. It's a very large molecule. It won't be absorbed from the gut. Therefore, if you're giving it intravenously, it won't be able to make its way into the gut. So it has to be given orally where it can reach the gut. Yep. So infective endocarditis, like I mentioned before, C. difficile, which we mentioned, it's used orally when used for the treatment of C. difficile. And it can be used for, glycopeptides can be used for hospital or community-acquired pneumonia. If you're using glycopeptides for C. difficile, the main glycopeptide you're going to be using in accordance with guidelines as well is vancomycin. You're going to be giving the vancomycin orally. AHMED has been prescribed vancomycin for diabetic foot infection. What side effects should the medical team monitor for with regards to vancomycin? Yep. What is red man syndrome and what increases the likelihood of red band syndrome? If you see the term vancomycin infusion reaction, this term is used interchangeably with red man syndrome, and this is associated with the speed at which you infuse the vancomycin. So if it's infused rapidly, if it's given too quickly, as people are mentioning, then that increases the risk of red man syndrome, where you've got this hypersensitivity reaction of the upper body, and you've got this entire redness of the upper body, which can occur with patients. It can also cause blood disorders, so it's very important to monitor a patient's blood counts. It can cause thrombocytopenia, so a drastic reduction in platelet counts as well. And what other side effects should we be monitoring for? Some we've already mentioned. Nephrotoxicity and ototoxicity as well, absolutely. So nephrotoxicity, ototoxicity, vancomycin infusion reaction, which is also red man syndrome, and blood disorders. It can drop platelet counts. In terms of blood disorders, what would you tell a patient to look out for? How may a patient see this? Unusual bleeding or bruising. Yes, absolutely. So sore throat may also be a sign of immunosuppression. Bleeding gums, bleeding via urine. Absolutely, very important to counsel patients on what they may see with regards to these adverse effects. Okay, so now we're going to go through. I'm going to